all the audience. I'm most grateful to you for joining us, and I hope this proves to be a fruitful session. My name is Stuart Watson. I'm a burn surgeon from Glasgow in Scotland in the United Kingdom. And this session is supported by BFIRST, the British Foundation for International Reconstructive Surgery and Training, the British Association of Plastic Reconstructive and Aesthetic Surgeons, the British Burn Association, and Research Africa, which supports reconstructive surgery and burn development in Africa. And also there's a strong participation from Interburn's international group, which has done fantastic educational development work in burns. So welcome to everyone. Here is our faculty for today for discussing infection in the burn injured patient. And we have Dr. Shobha Chamania, Director of the Burn Center at Choitram Hospital in India, Professor Peter Javolski, who's one of my contemporaries, who's a superb burn surgeon from St Andrew's Hospital at Chelmsford in United Kingdom, Ms. Pratibha Sharma, who's consultant dietitian from the Choitram Hospital in India and has a superb reputation as an educationalist in burn nutrition, Mr. Apoko Ampoma, who is the Chief Executive Officer and Head of the Burns Unit at Korle-Bu Hospital in Ghana. And this is the last one of this series that I'm doing, and I've indulged myself by welcoming four of my colleagues from my home unit, the Canisburn Plastic Surgery and Glasgow Royal Infirmary Burns Unit in UK, Mr. Nick Arkulis, burn surgeon, Dr. Leah Payton, intensive care specialist, Jackie Iveson, ward manager, Mike Basler, consultant anaesthetist. And they have been wonderful colleagues to me during my time in Glasgow, and I'm very grateful to them for joining us too. And finally, we have Mr. Olin Shelley, who's an outstanding burn surgeon and educationalist who works between the Republic of Ireland and the United Kingdom. So what I'd like to do now is to introduce and start our first speaker. I'm just going to close that presentation at the moment and then open her video. So this is Dr. Shobha Chamania, who is going to speak to us, give us a general overview of management.
Good afternoon and greetings from Choitram Hospital, Indore. To everyone, I'm Shobha Chamania from Choitram Hospital.
Can everyone see my screen share there?
To you
We can't, Stuart. It's not visible.
Okay. As we deal in our center. Initially, just want to thank the organizers and BFIRST and BBA for inviting me to be a part of this very important session on wound infections, burn wound infections. I'm very grateful to you all.
Can you see it now, please? Could someone let me know? Can you see my screen share?
Greetings from Choitram Hospital. Good,
Stuart.
To everyone, I'm Shobha Chamania from Choitram Hospital, and I'll be presenting to you the diagnosis and treatment of burn wound infections as we deal in our center.
If anyone has any questions, please put them in the question and answer.
And BFIRST and BBA for inviting me to be a part of this very important session on wound infections, burn wound infections. I'm very grateful to you all. We all know that the burn wound infections are a major problem for burn patients. They are almost unavoidable in our situation. And the importance is that they cause a lot of morbidity and they cause mortality or outcomes. So just to understand what are these and what are we afraid of. So the first ones, when the burn wound has happened, the barrier, skin barrier is broken, it is sterile. Then it slowly starts getting contamination by various people through which the patient goes, meaning various facilities through which the patient goes to reach the final burn center, leads to contamination of food, which is non-proliferating bacteria, and they do not trigger any host response to it. Then slowly over a few days, colonization occurs, which means that total colony count is less than 10 raised to the power 5, and this also does not trigger any host response. The local infection, which is the step 1 that happens from 5th day onwards, is defined by the presence deeper in the burn wound of microorganisms at a concentration more than 10 raised to the power 5 bacteria per gram per tissue, which proliferate at a rapid rate and triggers a host response. This is localized to the burn wound with no invasion into unburned area. So this is normally what we see. The invasive infection and the cellulitis, these two are further complications, which invasive infection is defined when these organisms invade deeper into an unburned area, leading to destruction of into the surrounding tissue of the burn wound, with microorganism concentration in same more than 10^5 that are associated with local and systemic clinical signs. So here the patient will appear definitely deteriorating, very sick. The infection is no longer contained, and it will involve deep tissue, muscle, fascia, or bone. Cellulitis is defined. This invasive infection is diagnosed by not only by the number of organisms, but by histology, where you see organisms entering into healthy tissue. Cellulitis is defined by the presence of advancing erythema, induration, warmth, swelling, tenderness around the burn wound edges, and it may be associated with signs of sepsis. These are the last two things that are indications for topical and systemic antimicrobial care, along with in the first one, invasive sepsis surgery is required. We all were told that wounds are sterile to begin with, and then they develop gram-positive organism in the first week. In the second week onwards, as gram-negative infection, fungal infection comes in because burns or non-burn reasons like HIV, chemotherapy, steroid therapy, diabetes, chronic liver disease, chronic kidney disease, all these can lead to immunosuppression, and the person will be prone to develop fungal infection. But the biggest cause in a burn setup is the use of broad-spectrum beta-lactam antibiotics for a long time, and this leads to fungal infection of the wound. And then these are also commensals in our body, so one can develop indigenous infection from GI tract or respiratory tract. There was a publication from India, so not that Indian setups are not having fungal infection. So this was in 2012 when they mentioned changing patterns of fungal infection in burn patients. They had reported that they see more of Candida non-albicans now, and that these are very morbid and fatal infections, very difficult to treat. So this was a very alarming paper. But in our setup, we have only 10 cases of candidiasis in last 1 year, and all of them are again diabetic sensitive to responding to treatment. Our main problem is gram-negative migrated resistance organisms. So, what are the risk factors that predispose a person, a burn patient, to develop infection? First, if he's got to be burned, like more than 20% total body surface area burn, has a significant amount of full thickness burn, or has inhalation injury, has other comorbidities like diabetes, and other reasons that can lead to immunocompromised status, as mentioned just now. If the patient arrives late in the unit with pre-morbid malnutrition and has extremes of age, associated psychiatric disorder, and non-accidental burn, these are the patients who are prone to develop infection wherever they are. But other infrastructures in the developed world have a better care facility. Our patients are not in isolated room. We keep patients at least minimum 2 in one room, and then max up to 4 in one room. The only way we can isolate is all pseudomonas can stay in one room, all fungal infection can go in another room. Every contact with the patient, be it for dressing change, which is happening in a common area, or for therapy, which is happening in another common area, can be a cause for infection. Along with this, we have a very high attrition rate of the trained nursing staff. Therefore, we have to keep training them. Otherwise, supervision gets much less focused on prevention of infection. And the family members' presence is almost always there. We have to keep training them. This is a typical inpatient room for the burn patient, and this is a family member, and here's the counselor who's trying to teach the family member do's and don'ts of care with the patient. The two dressing rooms are here. One dressing room is for the clean patient, the other one is for the dirty, infected wounds, and this is how we sort of separate the care areas. How do we diagnose burn wound infection? Very difficult clinically initially, because patients 15 to 20% burns would have hypermetabolic state, and this would lead to low-grade fever. Infections also cause low-grade fever, so difficult to discriminate from this vital signs that the patient's developing infection. But the first sign can be looking at the wounds frequently. And if you're looking at it, you can identify there's a change in the wound. If the superficial burn is becoming partial thickness is becoming deep, that means this infection. Or there's profuse exudate, there's foul smell, change in color. All that can help you to identify that there is infection. And then take a culture from the which organisms. It can also be unrelated from the wound. It can be from bloodstream, urinary system, respiratory system, and device. Showing you some of the cases where we can identify the infection. This is a chronic non-healed wound on the face, which is a very vascular region. It's a very pale, unhealthy, slimy, shiny dilation tissue, which is telling us that it is an infected wound, and you have to identify what organism it is. Can be a gram-positive or gram-negative infection. And commonly, the patient has perineal area, or the lower limb area close to the medial side of the thigh. Then endogenous infection occurs from this area, and the armpit axilla. This is the entry, and you can see the change of color happening on the other side of the thigh. If there is a blood central line access close to this from femoral then that's also going to be a cause of infection. And urinary catheter is kind of unavoidable in this situation. So that can also be a cause of infection in the urinary system. This is a historical patient almost 3 decades ago, came with invasive sepsis, a child with DIC and paralytic ears, cornea, and very sick. Unfortunately, they are referred to us very late when doing anything was impossible for us, and we lost this child. Invasive burn wound infection is continuing to come like this to us because these patients are treated in the rural area. And when the child becomes very dull, unresponsive, that's the time when the patient comes to us. So look at this unresponsive child with invasion in the lower abdomen, massive burn wound, and it's brought to us like this. On ventilator, good not salvation. This is a very alarming change in color, grayish color, extending very rapidly in the burn wound. Is one of the notorious Pseudomonas species which can be fatal. And this complete blackening with ectopic lesions occurring in the field scar on the unburned area in the scalp is a classic story of sepsis. Postnatal patient came to us like this, was being treated for burns in the lower limb, and she developed progressive necrotizing fasciomyositis, characteristic of invasive fungal infection. They kept on debriding and imputing it. Finally, when they saw that this is not stopping, they were referred, patients referred to us, and nothing would stop this progress. We even decided to get the hip, but it's quickly up. So, in a nutshell, we have to understand that these infections are fatal, and it is best to prevent them. Coasting graft syndrome is probably seen by most of the burn surgeons here. We're familiar with it. The cause is human collagenase being released by the body to digest the necrotic tissue. If the excision was done inadequately, then the area under the graft is being digested, and so the graft gets injected, or there can be an infection in the body, and that can enter with the graft. So culture and treating that wound is required. Chondritis is another infection that happens much later after one wound is made. Patients usually present with swelling in the ear, very severe painful swelling. And underneath here, anesthesia is retrieved the first. It will remove all the granulation tissue and the dead cartilage. Then you can cover this wound to help expedite this healing process of chondritis. We have done a flap cover of the organ flap, which has corrugated chain, sutured possible wounds here, and then grafted the anterior part of the body. Invasive infection, excision of the invasion, including all non-viable tissues, and then cover this wound with allografts after a good wash. After day 4 or 5, we remove the allograft and replace it with the autograft in the patient's story. Antibiotics in this case are given as per the antibiogram for 2 days, and then we wait for the report, culture report, change it according to this culture. These grafts are then covered with topical acetic acid solution or sodium hydrochloride solution, and if possible, they are fixed in a limited access dressing. What is limited access dressing? The limbs are enclosed in plastic covering with the 2 rice tubes inside. One is for washing and the other one is for suction. So you can use saline to wash, or you can then put acetic acid or sodium hypochlorite for about half an hour one time and then suck it out. So this helps in sucking all the exudates, organisms, inflammatory mediators, and therefore toxemia reduces. It reduces the pain and anxiety from the patient's point of view. If you're going to be a frequent drink, this reduces the frequency and is also this way reducing the cost and effort of dressing. The best part is that because it is covered and closed in a plastic shield, it isolates the infection and it prevents cross-infection, especially in our type of setup where we don't have isolated for each individual. This is a very nice paper by Dr. Prabhu Kumar on limited access. What are the organisms that were seen in 2020 in our setup? Acinetobacter, which was resistant to all except colistin and polymyxine. In 20, the Staph aureus also showed some good response to antibiotics, but in 22, we have Acinetobacter that is 100% resistant, and Staph aureus and Pseudomonas are 50% resistant to microorganisms. They are resistant to all antibiotics. So now the big question is that if we have taken a wound swab or a culture and we have a report, are we supposed to give antibiotics? To answer this question, we looked at the review article in Cochrane Library on antibiotic prophylaxis for preventing wound infection. The available evidence is limited in general. It does not demonstrate that antibiotic prophylaxis reduces the risk of burn wound infection, invasive infections, or mortality associated with infection. And therefore, we have to choose not to use antibiotics frequently in the patients. Then, how do we treat the infections? So we used to use 2.5% acetic acid, and patients will have the complaint of pain. And there are some toxicity mentioned in literature. We had not seen so much, but pain and discomfort was there in patients. So this was a very important paper in 2015, which is talking about the antibacterial activity of acetic acid against biofilm-producing pathogens of relevance to burn patients. And they tried dilutions much less than 2.5%, and they said at 0.31% also, it has very good activity on almost all the organisms and even reduces the biofilm biomass significantly. So this was a very landmark paper for treating burn infections. Especially due to current concerns of the reducing efficacy of systemic antibiotics, this becomes a novel biocide application with great promise, very cheap and effective measure to treat infections in burn patients wherever, be it the developed world or the developing world. Hopefully, this will also have this toxicity. Another solution that is very commonly used in our setup, and I think globally, because this has been in practice for centuries, at least for more than 70 years in field, to use it as a bactericidal agent on the infected foods. The concentration recommended now is 0.006%, which is suitable for topical management of burn wound infections caused by common pathogens. It has a shelf life of now 6 days. Earlier, it used to be 24 hours. So this is also cheap and easy to prepare. It's not a buffered solution. Buffered solution is not available in our country and it's not available universally. So this was the research done by South African team of Professor Heinz Rode and his team. And they have shown that this is equally effective and it does not affect the healing of burn. So what are the treatment principles in general? Silver sulfur cream is the first topical to be used if you're not going to do anything else. Otherwise, superficial second degree wound, we cover it with biological collagen sheet. If it is a full thickness burn, we do an early excision for deep dermal and full thickness burns. If there is a wound infection, then it is managed with these two topical biocide, acetic acid and sodium hypochlorite. Silver dressings are used, but very sparingly because they are expensive. We do not have maconite acetate, and therefore the chondritis cannot be prevented. Cerium nitrate or nitrofuran are also not. Just an example to show that this patient was excised and grafted, and these were the areas that we thought that maybe this would heal spontaneously. So we had used fish collagen for this. And patient developed infection because she had invasive infection in the inner side of the arm. So she developed infection and lost this area of graft partly. And in 10 days with acetic acid and sodium hypochlorite later, this wound has completely cleaned up. You can see epithelial edges have healed from the periphery, showing that it's now the right time to graft this wound. And it stopped the rejection of grafts. So this is how these new topical biocides help us to contain the infection and prepare the wound bed for skin grafting. Then this patient was grafted. Infection control practices are very important for burn unit, and we have to make sure that we implement all the contact precautions and hygiene for PPE, environmental disinfection for the unit. Isolation of patients as much as possible. Training has to continue for health workers and patients' families. This is how we can contain the infection. Otherwise, we've had to close our units several times because of epidemic of infection, which are drug resistant. Any invasive device has to be used, especially with the second thoughts that they are absolutely mandatory, that we cannot do without them, and they must be removed as soon as possible, because the longer you keep these things, they'll be the cause of infection. The monitors BP cups are all individual for the patient. They are only sterilized terminal when the patient leaves the ward. This is very important. Burn wound surveillance, I think, is the most important thing for looking, preventing or identifying the burn wound infection. Every change of dressing must be seen by the treating surgical team member. Any change they will identify and then do a culture, plan surgery, or start medicine. Why do burn units have so much infection? Because these organisms are resistant to the antiseptics that are usually used, and they remain viable on dry surfaces for a very long time. 16 months to 7 months to 5 months, so they just stay there for a very long time. It's a question of survival at this time. So what are the ongoing needs for us? We have to improve the communication between the receiving center and the referring center to receive the patient much earlier than what we do today and in much better shape. And we have to do continuous training and education of the burn team members in our own setup and in the region where we stay. Prioritizing wound inclusion. This is one more emphasis that I want to make here, because I have visited some centers where granulating wounds were being dressed for months and a year, waiting for it to become ready for graft. You don't have to wait for so long. Granulation tissue will always have some organism, and we always remove them before grafting. So there is no need to wait for very long. As long as you've done a good cleaning, you have to go ahead, take a chance, and do a skin grafting. To summarize, infection control practice being rigorously implemented, wound surveillance, antibiotic stewardship, and encouraging the use of topical biocides are important to contain the burn wound infection and then prioritizing wound closure and managing optimal nutritional intake should improve the outcomes. Thank you once again to the team for inviting me, and I'll be happy to answer questions. Thanks.
Thank you so much, Shobha, for a superb presentation. Apologies for the sound there. I think it possibly relates to partly to my computer here. First of all, I just want to ask some questions of Shobha, and then Jackie, our ward manager, and Peter Jaworski regarding the wound management. Shobha, I was very interested that you recommended the biocides, acetic acid and dilute sodium hypochlorite, and they're both very, very cheap and readily accessible. And can you just tell us that, you just talk a bit further about that, because you clearly find those both very effective but also cost effective.
Yes. See, most of our patients are, they have to pay from their pocket, and burns is a disease of poverty. So generally the patients are poor, and we have to really worry about the economics, the cost of treatment. So silver dressing is very sparingly used because it is expensive. And these two dressings are used from post-excision onwards till the graft take is around 11th day of post-operative wounds. We would use Gamgee soaked in one of the solution. Generally, it is the unbuffered sodium hypochlorite that we use, and over that a dry Gamgee. And this, sometimes we keep tubings to keep on instilling these solutions till day 5, and the first change of dressing is on day 5, and we have had very good results with this. So we're not using silver dressings. That's fine.
Thank you so much, Shobha. I'd now like to just ask Jackie, ward manager from the unit in Glasgow, tell us about your experience of using acetic acid, Jackie.
Sure. So we've used acetic acid on mainly our bigger burns. We have shower trolleys, and we would go to patients who are in ITU, and we would use these shower trolleys to wash the patients down in acetic acid, a diluted solution. We've had really good results with that, and we would usually do that every second day, and certainly we've had great results, and we'll continue to do that.
Thank you very much, Jackie. And now, Peter, may I please ask you, Professor Jaworski, about your opinion about materials such as acetic acid and dilute hypochlorite. I remember when I was a trainee contemporaneous with you back in the dark ages, there was a great paper from Martin Robson in the US about sodium hypochlorite on burns, and we went through a phase of using it quite a while. What are your views about use of it?
Yeah, no, we've used it for 20 plus years, and well, since obviously Robson and Heggers, it was, I think, won a prize on it, looking at the concentration. And I think, as Shobha has said, if you use it at a weaker concentration, it usually comes at 0.1%. If you dilute that at a quarter strength, actually it's toxic to bacteria, but not to human cells. I think the problem with hypochlorite has always been that it was banned in our professional lifetime in the UK by our tissue viability colleagues because of studies that showed it impaired wound healing. And actually those studies were very scant in terms of what they looked at, animal models particularly. So it's always been very effective in burn care. And I think with Heggers's solution, as we would call it, it's actually very effective, but I think it's fairly rapidly inactivated, which is the same comment I would make about acetic acid. Acetic acid, particularly good for Pseudomonas, but I think inactivated on contact with the wound, and therefore you have to keep reapplying it, which usually means the room and then the unit starts to smell after a while a bit like a chip shop. So, but both very effective topical and cheap antimicrobials. And I think it's also important the way the hypochlorite, going back to that, is prepared. And I think it's the hypochlorous acid rather than the hypochlorite that's the effective agent. Can't hear you.
I muted myself too, so I didn't interfere with your words of wisdom.
Yeah.
Thank you so much, Peter. Peter, I was really struck by Shoba's isolation dressings, which seem like a mixture of relatively low cost but a very sophisticated concept. Do you have any views about that?
I thought that was a great idea, and obviously, I'm obviously going to look that up and look into it. I think one of the problems, particularly within cross-infection, as I think I'll go on to in my talk, it's really nothing to do with surgery. It's all about infection prevention, infection control, which we as surgeons are particularly bad at in general. It's actually all the equipment and stuff that's actually in the rooms with the patients will harbour bacteria, and it's actually eradicating those to reduce cross-infection that's really important, particularly with the spread of the MDROs, the multi-resistant organisms. So that thing, as I say, I've not seen that before, but that looks like a great idea.
Yeah, thank you. That's what I thought as well. Thank you so much for your comments, Peter. And thank you, Shoba, for a wonderful presentation, really comprehensive, but also with some really innovative ideas for people to think about. So just bear with me, the audience, while I commence the screen share for Professor Peter Jaworski's recorded presentation. And I'm hoping that I can. Can everyone see that all right?
Hello, my name is Peter Jaworski. I'm recording this prior to the meeting, but we'll be there for questions. So I'm a plastic.
Excuse me, I'm sorry, I'm just going to pause that and close it because it's not the best version. Just bear with me for a second, everyone. My apologies. Please, may I just check? Can everyone see this all right?
My name is Peter Jaworski. I'm recording this prior to the meeting, but we'll be there for questions. So I'm a plastic and reconstructive surgeon. I work at the St Andrews Centre for Plastic Surgery and Burns here in genetics. I've been asked to talk about management of bone wound infections, and I'd like to thank the organisers, BFIRST and BFIRST, and particularly Stuart Watson, for the very kind invite. I'm honoured to be amongst such esteemed company around the world. I'm going to talk mainly about burn wound infections, the use of antibiotics and surgery. So burn care is given via the multidisciplinary burn team, and a key member of this team is the microbiologist. We've been very fortunate to have Dr. Louise Tier supporting and working with us for the last 25 years. She's a fantastic microbiologist, has made a great contribution to the service and to burn care in general. And she unfortunately can't be with us here today, but I'm showing some of her slides, the thoughts on the issue. Of course, the first burn unit was set up in Edinburgh in the 19th century by Joseph Lister, the father of asepsis. And why did he do this? Well, his professors had said that the burns admitted to the general hospital there at the time stank all the wards out and all the other patients. They were known as black sheep in surgical wards. And why is this? Well, a human being contains 10 to the 14 cells, but 90% of these are not human. We are full of bacteria and other organisms. And this was a favourite saying of my great friend and colleague who recently passed away, Bruce Philp, who I worked with for a long time on the burns unit. And this talks in memory of him. So there have been many advances in burn care. I'm sure you've all seen this slide before, but you can see here in the 1970s, with the advent of flamazine, sulfadiazine, and early excision, mortality outcomes improved really quite dramatically. It's still a problem, and we looked at this some time ago now, and we looked at autopsy finding in our burn patients, where we found still a significant number of patients were dying from infection and sepsis. But when we looked at what organisms were causing the sepsis, the majority of these were, in fact, sensitive organisms, with only about 16% of deaths were related to multi-resistant organisms. The commonest sensitive organism that was causing trouble at that time was Pseudomonas, followed by fungus and staph, with, as I said, only 60% accounted for by multi-resistant organisms. So bloodstream infection, following an infection, really has quite a significant impact on both mortality here, over 20% risk of mortality if you have a bloodstream infection following a burn, but also increased morbidity in terms of length of stay, number of days in ITU, and number of days on a ventilator. So infection, and particularly bloodstream infection, really has quite a significant impact on our patients. So where does burn infection and sepsis come from? Well, it can either be endogenous, the organism can be endogenous, particularly the wound, the guts, who we've already discussed, any indwelling catheters, such as central lines, urinary catheters, and those patients, particularly on a ventilator, are prone to pulmonary infection. Exogenous causes and sources are the environment, equipment, but also staff, and this really does increase the risk of cross-infection between patients, and therefore a very, very serious issue that needs addressing. So this is a child with serious wound infection. Here, overwhelming pseudomonal wound infection, ecthema gangrenosum, and all wounds following a burn are sterile. They then become contaminated and colonized, and as the number of organisms in the wound grow, local invasive infection followed by systemic invasive infection occurs. Signs can be relatively difficult, but the traditional ones of redness, inflammation, swelling, pain, discharge from a wound, an offensive smell, and an unwell patient with a fever are all fairly typical. More specific signs, particularly related to bone wounds, where one needs to consider infection, are if a partial thickness wound progresses to a full thickness wound, there's a change in colour, green discoloration, biolaceous discoloration, there's edema around the wound margin, or if you start to see subeschar hemorrhage or eschar separation rapidly, these are all can be subtle signs indicative of infection. Systemic infection, bone wound sepsis has always been difficult to diagnose. The ABA issued a consensus statement of systemic size that would include hyper and hypothermia, tachycardia, increased ventilatory requirements, thrombocytopenia, glucose intolerance, and intolerance of enteral feeding. These all can be quite valuable signs in diagnosis of wound sepsis or burn sepsis. Patients' risk factors would include extremes of age, comorbidities, particularly obesity and diabetes, immunosuppression, these invasive devices that are already discussed, burns over 30% total body surface area, deep burns, and wounds that actually fail to progress in terms of healing, which can be due to infection itself or can cause the infection, and inadequate or improper early burn care can all contribute. Which organisms cause infection? Well, gram-positive ones such as Staph aureus, Streptococcus, and then later on gram-negative ones such as Pseudomonas and gram-negative bacilli, including carbapenemase-resistant Enterobacter, Acinetobacter, an increasingly common wound isolate, and then later on in the patient's treatment, fungal infection with Candida aspergillus, and around the world, more invasive fungi such as mucormycosis can all be very problematic. Anaerobic infection is, I think, uncommon, particularly in my experience. So we've looked at our microbiome, what our patients grew, and this was a snapshot taken quite a while ago. And the organism that sat that stage that predominated were coagulase negative Staph epidermidis, Staph aureus, particularly on emission cultures. As time progressed, gram-negative started to predominate, particularly Pseudomonas. It was of note that no VRE or MRSA were noted on a common basis. These were uncommon. Wounds are initially sterile. They are colonized within usually 48 hours by microorganisms from the skin, sweat glands, and hair follicles. Gram-positive organisms, as time goes on, are replaced by gram-negative ones from the patient's gut flora, and usually at about a week following injury. If the patient's wound remains open or there's a prolonged stay in intensive care, particularly, wounds and patients can become colonized with a variety of fungi, which we discussed. Gram-negative wound infection is a worldwide issue, and here a meta-analysis and systematic review by Ernesto Azzopardi really demonstrate that papers published all around the world, Pseudomonas still remains the commonest organism producing wound infection in hospitalized adults with burn injury. We've more recently, in the last decade or so, are moving into a post-antibiotic era, particularly with carbapenemase producing Enterobacter, CPE, and MDROs, multiple drug-resistant organisms that are now, we are seeing bacteria that are resistant to all known antibiotics. So we are moving into a post-antibiotic era, which obviously has severe implications for our burn patients, but also all our other patients. This study from the Shriners, actually published a little while ago, showed that when they reviewed their deaths, as we did, the vast majority of their deaths were due to drug-resistant organisms. More recently, Heather Cleland in Australia published this study, which showed analysing MDROs in a burn unit, that they, although in over 2,000 admissions, the MDROs that they were growing varied, but acquisition rates were stable, and about 11% of their patients became colonised with these organisms, the commonest being Pseudomonas, the commonest early ones being MRSA and Sternotrophomonas. The acquisition times were about 10 days for Staph MRSA and about 3 weeks for resistant Pseudomonas. They also found that patients with MDROs were older, had bigger burns, had a longer length of stay, and had more surgical interventions. They could not determine a relationship between antibiotic exposure, how long, or which antibiotics the patients had had and the emergence of MDROs. Infection prevention is really key, trying to stop this. And this will involve microbiological surveillance, which we've discussed, close liaison with a microbiologist and regular wound swabs. I think quantitative microbiology has been shown not to be that effective recently. Environmental decontamination to help prevent cross-infection in particular is also very important. So the use of topical antimicrobials, which we'll go on to in a minute, particularly those silver-based ones. Washing wounds is key. Here's a child with a 70% burn being placed in the shower. Washing wounds, I think particularly showering them, has been shown to reduce log count. It has shown log count reductions in the number of organisms grown. However, I cannot find the reference for this, so if anybody knows, I'd be very grateful if they would let me know. I've seen it presented on numerous occasions. Other prevention strategies that are really important are good hand hygiene, as we've all learned during the pandemic, contact precautions, cohorting of staff, particularly nursing staff, in those patients who have resistant organisms, the minimal use of invasive devices if possible, the use of antibiotic stewardship, using focused antibiotics for short periods rather than prolonged continuous antibiotic usage, and the use of screening to identify what organisms and their cultures and sensitivities are all very important in trying to reduce the risk of and manage the risk of infection in our burn patients. Recently, we had an Acinetobacter outbreak in the unit, which Louise Tier and my colleagues published on our response to this. And here you can see the sort of detail of the amount of cleaning of not only the rooms, the equipment, but also the staff that was required to eradicate this resistant organism outbreak and prevent cross-infection. Topical antimicrobials have been used for a long time, and as I said earlier, the use of sulfasaliflodazine in the 70s did significant impact on mortality. These are all currently still all in use, and I'm not really going to discuss them much further for time limitation. What about patients who develop sepsis? Well, as with intensive care medicine, burn medicine, I think really have it goes along similar principles. Here, the Surviving Sepsis campaign, patient resuscitation, diagnosis of the infection, the use of appropriate antibiotics, and source control, which in our patients usually means surgery and wound excision. So antibiotic therapy should be targeted. We should be selecting the antibiotic with the greatest antibacterial efficacy in a concentration at the infection site high enough to kill the targeted pathogens. This for a vast majority of our antibiotics will require intravenous infusion to get the right tissue concentrations. Antibiotics should be used appropriately to try and limit the use of development of resistance. So continuous courses of the same, particularly the same antibiotic, should be avoided. And we've already said high standards of infection prevention and control will prevent unnecessary infection and therefore use of antibiotics, and furthermore, the development of drug-resistant organisms. So when we looked at the microbiome in our burn patients, the commonest antibiotics being used at that time were gentamicin, meropenem, piptazobactam, and vancomycin. We have described the use of colistin for the management of some of our multi-resistant organisms, and this has been very, very effective for us. The BMJ some time ago now published a systematic review of meta-analysis. They summarised and concluded that limited perioperative prophylaxis could reduce wound infections, but had no effect on mortality. They looked at topical antibiotic prophylaxis and showed no beneficial effects. The main thing that they highlighted was the quality of the evidence was very, very weak. And despite it showing reductions in all-cause mortality, antibiotics causing reductions in all-cause mortality, they surmised that prophylactic systemic antibiotic prophylaxis was not supported by the evidence currently. So which leads us on to source control. Infected wounds often require surgical debridement if the patients wounds are deep, particularly if there's necrotic tissue there. And as you can see here, it's often a very bloody procedure. Certainly infected wounds bleed more than non-infected wounds. There's good evidence for surgery reducing colonization and invasive infection. Here, John Barrett published, I think, nearly 20 years ago, this study that showed reductions of bacteria in deeper tissues following excision, and also reduction in wound infection in those patients undergoing early excisional surgery. However, even following surgical excision, bacteria do remain on the wound. Here, in a not a burn wound, but I think in a diabetic wound, you can see that both Versajet hydro debridement and surgical debridement reduced numbers of bacteria here before and after with log count reductions. But some of the bacteria still remain. Why is this? Well, I think more and more interest has been shown in biofilms. They're very difficult to remove from surfaces, not only the wound surface, but also in equipment in rooms, and physical removal with cleaning agents, high pressure washing and sonification have all been investigated. The key for us is that actually debridement of dead tissue is really important, as that's where bacteria gain their nutrition. And also surgical debridement disrupts the physical structure of the biofilm. So surgery in infected wounds is important. So to summarise, infection really remains a major factor in burn mortality and morbidity. Diagnosis can be difficult, and microbiologists are a key member of the team. Surgical debridement, antibiotic use, and particularly antibiotic stewardship are very important. And I think I'd like to leave you with as we're probably all aware, that MDROs are an increasing threat to not only our burn patients, but to all the patients that we treat. Thank you very much.
Thank you very much, Peter, for that wonderful talk. So I'd just like to bring in my colleague, Nick Arkulis, who's a burn surgeon from Glasgow and an immediate colleague of mine until I retired recently. If I could just ask Nick about what's your view about proceeding to excise infected burn wounds? How do you prepare for that if you have a patient who has an infected wound? What sort of things do you think about when you're setting things up? Because as Peter alluded, it's potentially quite a bloody procedure and quite challenging.
Hi, Stuart. Good afternoon, everyone, and thanks for inviting me. Yes, once we've made the decision to take an infected patient with an infected burn wound to theatre, we do so, is an MDT decision. And as you say, our key strategies are to actively prevent hypothermia and try and reduce the bleeding. So again, we're trying to have the same theatre with the same staff that know what they're doing with the right equipment. We would like to have an anesthetist that specializes in burn care for larger burn patients. And then specifically for hypothermia, we don't have radiant heaters in our unit, as you know, which is, in my opinion, the most effective way to heat a patient. So we rely on other measures. We rely on the ambient temperature. There's some evidence to suggest that if the ambient temperature in the room is over the latent heat of water, which is about 31 degrees, that prevents evaporative loss. We warm up all our fluids, all our prep, dressings, everything. We use underwarmers and overwarmers, and we sequentially expose the areas that we would like to treat. And also recently we have used ThermoGuard, which is an intravascular heating device or cooling device, which essentially through a central line, a balloon is inserted in the inferior vena cava, and that circulates either hot or cold water. We found that to be more effective in cooling patients than actually warming them up. So the idea that we had that we could fully expose the patient and just use a ThermoGuard to keep the temperature did not really materialize. So we have to use all the other measures that I mentioned. And then it's the surgery itself afterwards. So we just, I don't know if you want me to go through this now or a bit later.
That's great.
Yeah.
That's super. And I just wanted to bring you in at this stage because to introduce and you said it right at the start of your answer, that later we're going to have a discussion about the multidisciplinary approach to taking difficult burns patients, infected burns patients to theatre. And Peter rightly showed there that it is a challenge, but also Peter showed that one of the key things with infected wounds is if you can debride them, you significantly reduce the source and you reduce the potential for invasive infection. And I think Shoba also showed strategies for doing that. I'd like to now ask Leah Payton, consultant in intensive care. Peter indicated an aim to reduce the number of invasive devices, but obviously in intensive care, you need invasive devices often to look after the patients. How do you deal with managing the invasive devices for monitoring and for access in burns patients to try and achieve to some measure the goal that Peter explained of trying to avoid exposing the patient to infection from invasive devices?
Yeah, it's a very good question, Stuart, and I don't think one that we have an easy answer to. I think for lots of our burns patients, there are discernible phases within their critical care stay. So there will be the sort of acute phase where they're undergoing their initial debridement and resuscitation and grafting, where they very much require the multi-lumen access that a central line provides. But moving beyond that, you get to phase where they're in the more sort of rehabilitative phase of their critical illness. And within that phase, you're looking to get the pieces of plastic out as quickly as possible. Sometimes you can't do that with a single central line. And when it becomes apparent that you're dealing with an infective issue, you then need to consider whether the central line is the source of that infection. And we would generally do sampling of the central line as a means of guiding whether that central line was the source of any infective problem in that burns patient, as a forerunner potentially to changing that line.
Thanks very much, Leah. So moving on now, I want to introduce our next speaker, Pratibha Sharma, who's a specialist dietitian, and she is again given me a recorded video presentation. So please bear with me while I just start that. Whilst I'm doing that, I just want to do two things. I want to thank the audience for joining. We have about 180 participants and from all over the world, and I just want to thank you all for joining us. And I hope you're finding that this is worthwhile, but it is just wonderful for us to have such an audience with us. And finally, before I start Pratibha's presentation, I just wanted to also pay tribute to Bruce Philp, Peter's colleague who died, and to recognize his fantastic contribution to burns. And I just want to thank Peter. Peter Javelski is a contemporary of mine who's been an absolutely superb leader for burn care in the United Kingdom during his career. And you could probably get an idea from his talk there of the vast amount of evidence-based and extremely thorough work which he has done. And I'm so grateful to Peter for joining us today. And I just want to recognize what he's done in burn care in the United Kingdom, and thank you. So introducing now Pratibha Sharma, specialist dietitian from Choitram Hospital in India, the burn center there. And she's going to talk to us about nutritional management for catabolic burn patients.
Very warm welcome to one and all. First of all, I would like to thanks to BFIRST, BFIRST, and Research Africa for giving me this wonderful opportunity to talk about nutrition management for catabolic infected burn patients. Dear friends, catabolism is a set of metabolic pathway that breaks down the larger molecules into the smaller units in the form of glycolysis, proteolysis, lipolysis, either oxidized to release energy or used in other anabolic reactions. And they mostly breaks down total body mass from the fat and muscles. The effect of catabolism in the burns are significant weight loss, muscle wasting and bone catabolism, growth retardation in the pediatric burn patients, immunosuppression, infection and graft rejection, and ultimately sepsis and fatal situation. So the established research have shown that 10% loss of total body mass leads to immune dysfunction, 20% to decreased wound healing, 30% to severe infection and sepsis, and if it is 40% or more than that, definitely death. The primary mediators for catabolisms are catabolic hormones like catecholamine, corticosteroid, inflammatory cytokines. They work against the insulin and establish a state of increased lipolysis, proteolysis, gluconeogenesis, and high energy consumption in the burn. That's what they lead the risk of weight loss, muscle loss, skin graft failure, and wound infections. So the severely burned patients have a nitrogen loss of 20 to 25 grams per meter square TBSA per day, which if left unattended, results in lethal cachexia in less than a month. The primary objectives are to diagnose catabolism timely and initiate nutrition support as soon as possible to find out their pre-morbid nutritional status and post-burn days with nutritional supplementation history, to find out the risk of refeeding syndrome, because most of these patients are at the risk of refeeding syndrome. So individualized and customized nutrition support is crucial with close monitoring in these kind of patients. This is a 29-year-old male who got admitted to our hospital with a lead history of 35% total burn surface area. It was an accidental electric flash burn, and he received primary treatment at the nearest hospital, and he arrived to our hospital after the 7th day of the burns. His admission weight was just 53 kgs. His height was 183 centimeter. And the BMI was just 15.86, which indicates severe malnutrition. He was 30 kg underweight than his ideal body weight. So the nutritional diagnosis for this patient was severely malnourished, 35% TBSA at higher stress condition. And so he was a typical case of burn cachexia. The nutrition calculation we have done by using Carreri formula, and protein by using 1.5 grams of per kg ideal body weight with the addition of wound protein losses until his wound was not covered with the grafts. Also, we added micronutrients as per our standard protocol, which is vitamin C supplement 500 milligrams twice in a day, vitamin E supplement 400 milligrams once in a day, a multivitamin supplement which contains zinc, selenium, vitamin B complex once in a day. So the calculated calorie and protein was executed through the oral mode of feeding with 3,475 kilocalories and 125 grams of protein per day. The initiation of above calorie and protein execution was done by 1/4, 2/4, 3/4, and full strength by end of the 2 weeks. Depending upon his tolerance, we increased gradually the amount of calorie and protein in his diet. Also, we added anabolic steroids to reduce the metabolic rate with strict vital monitoring, especially heart rate monitoring and blood pressure for 2 weeks. We added whey isolate supplement in his diet so that we was able to achieve his protein requirement in low volume food in his diet. Daily monitoring and reassessment was done for him, and we monitored 24-hour diet recall with GI symptoms like vomiting, nausea, loose motion, and abdominal distension. He had sick days also during his hospital stay. The weekly monitoring was done by weighing his weight, wound size, and skin graft measurement, along with the other clinical condition. And this patient stayed almost for a month with us, and the burn size was reduced 35 to 30%. So he was just left with 5% burn, and he got discharged happily from our unit. Another case of a 13-year-old boy with 25% total burn surface area, again an electric burn. So his admission weight was 30 kg. His height was 152 centimeter, and the ideal body weight for him was 52 kgs. Calorie protein requirement was again 3,750 kilocalories, 93 grams of protein per day. Mode of feeding, we used oral and enteral both because it was a challenge to feed this boy. He was very stubborn and rigid, and he was not eating appropriately through the oral route only. So during his 30 days of hospitalization, we maintained his nutritional demand, and his wound healed, and he gained 5 kg weight at the time of discharge. This is another case of a 35-year-old female with 20% TBSA. She was a flame burn case, and she arrived 1 month later than the injury. So this was a typical case of refeeding syndrome where we have multiple factors along with the burns to manage. So the nutrition prescription for this patient was a bit different than the other patient because this was a late or delay arrival to us. She was an infected burn patient, so the clinical or medical team managed the infection part, and we started nutrition provision. So the energy estimation we have done by using 20 kilocalories per kg of the body weight per day. Protein we have given to her 1.2 grams per kg body weight per day. Carbohydrates 60% of the total calories, and fat 20% of the total calories, with added omega-3 fatty acid in her diet. Micronutrients, especially we focused on calcium, phosphorus, magnesium, and zinc in her diet. So the take-home message I would like to share here is to diagnose catabolism at the early stage so that timely management of nutrition support can save these severe burn patients. Anabolic steroids are really, really helpful to reduce the hypermetabolic or catabolic load. So use them if your patient requires, and if we can assess them timely, we may save them from the fatal situation. Thank you very much.
Thank you, Pratibha, for that superb presentation. Just for a comment to begin with, you can probably see, members of the audience, that whilst the Choitram Hospital in India works in an environment which many countries in the world would regard as a resource-limited environment, it is no barrier to them providing excellent, outstanding care. And Dr. Chamania and Pratibha and colleagues have led that to the extent that it's now a centre which sets an example to colleagues around the world. Pratibha, you emphasized anabolic steroids, and working within a relatively resource-limited setting, how does anabolic steroids sit in terms of being cost-effective? What's your position about that?
Yeah, I mean, in some cases, we are limited with the funds, but wherever we have the opportunity to prescribe these anabolic steroids, or if the situation is very crucial, sometimes we recommend all these added things in the prescription, because that really helps. So adding the anabolic steroids or whey protein, I mean, we have calculated the cost of the hospital stay. So these substances actually reduces the cost of treatment also. So in a other way, we are reducing cost and then the days of the hospitalization by using these.
Thanks very much, Pratibha. I'd just now like to ask Professor Peter Javolski. Peter, are you still on the call? Peter may have had to go. I'll ask Dr. Nick Arkoulis then. Nick, obviously Pratibha has joined us because of the importance of nutritional management for the burns patient, but as a burn surgeon, could you give the audience a further perspective on how important you feel this is for the infected burn patient? Just give us your views on that.
Yeah, thanks, Stuart. I think it just boils down to the fact that most of the burn patients with large injuries typically come from socioeconomically slightly poorer backgrounds. So it might even be, apart from the big insult that the burn has on their nutrition, their baseline status is often poor to start with. So the dietitian in our team not only has to deal with the added requirements from a burn, they also have to, in many ways, make up for the fact that when they came into us, they were quite poor nutritionally. So we have a dietitian in our team that joins us every Wednesday in our MDT, where we discuss all the patients. Our ICU patients have their own dedicated dietitian, and we use the MUST score. I'm sure, Pratibha, you would know that. I don't know what your views are on that, but we score everybody that comes in on the MUST scale, and if they score 2 or higher, we refer them to our dietitian for extra input.
Thanks very much, Nick. And Leah.
Thank you, Stuart. May I enter? May I? Yeah. To answer Nick, I just wanted to add on here that when you are calculating a MUST score, that we consider all our burn patient, major burns, as a critically ill patients. So in such situation, it is mandatory to see each and every burn patients in our unit. So that is why we don't calculate these MUST score, because we consider them, they are already into the high stress situation. So they need nutrition support aggressively. So because of that, we don't do that.
Absolutely, but sorry, I should have clarified. I meant in the kind of everybody that comes through the burns unit. But as you say, exactly, the critically ill ones will get the dietetic support straight away. You're absolutely right.
Thank you.
Thanks very much, Nick. I think your point's well made, Nick, and as well, because in some of the patients with smaller full thickness burns, both adults and children, it's very important not to ignore their nutritional requirements just because it is a small burn, because they're sometimes, as you say, that they need just as much support nutritionally to achieve good healing. And we found, dealing with our pediatric population, similarly from children from relatively more socially disadvantaged backgrounds, that some of them really benefited hugely in healing from supplemental nutrition, even for relatively small burns. Can I just ask Leah Payton from intensive care about advice about optimizing nutrition in the intensive care critically ill scenario, Leah? Any comments about that? Because sometimes it can be quite difficult feeding patients who are during critical illness. And what would you add about that, please?
Yeah, so a couple of points. We're obviously very well informed by our dietetic colleagues like Pratibha, who keep us on the right track. But what we need to monitor beyond what we're giving the patients is how well that transits the GI tract. We're not actually getting a measure of how well that's being utilised, but the surrogate of what your aspirates are doing in the context of your critical illness, so your NG aspirates, is the best we have in terms of the efficacy of enteral transit and absorption. We also need to try and minimise the perioperative fasting, and this is something that I guess my colleague Mike will touch upon. With repeated trips to theatre and the usual practice of preoperative fasting that is generally associated with that, you can find that with critically ill burns patients, you have extended periods of fasting when you're going on to repeated emergency lists. And we try and keep that as short as possible by running the feed up until the point of transfer to theatre, and sometimes even through theatre if there's no airway intervention planned, and if, as I say, the NG aspirates have been minimal, indicating that you're getting GI transit, all with a view to try and optimising nutrition.
Thank you very much. Thanks. Peter, I think you briefly popped out, and thanks for those very helpful insights.
Yes, sorry, my computer ran out of power, so apologise.
Not at all. That's great. Thanks for rejoining. I just wondered if I'd asked a sort of broader question of you, or was about any emphasis that you would put on the broad role of nutrition for the infected burn patient.
Yeah, obviously it's critical. Part of the problem is that often when patients get septic, they then get feeding intolerance, so it's very difficult to feed them. I think jejunal feeding rather than gastric feeding is probably beneficial if you can get a jejunal tube in, either using the skills of your anaesthetic colleagues, or placing them endoscopically. Obviously, calorie requirements in septic patients go up as well, so it's often difficult to get that. The role of TPN, I think now has come back into favour. It was out of vogue for quite a long time, so it goes waxes and wanes, but I think it is a critically important issue. Thanks
very much, Peter. Excuse me, audience. I'm just going to communicate with Nick Arkulis because about a business issue. Nick, it looks as if Dr. Amproma may not be able to join us. It looks like he may have an internet problem. So I think you're next to speak. So if you could, this is going to be earlier than you anticipated. So if you could just get ready. And finally, in terms of asking questions about the nutritional aspects, Jackie Iveson, from the nursing aspect of things, tell us how your staff regard nutrition and as a priority and manage that in the ward environment.
Yeah, it's a huge priority for us. Obviously, our big burns have got our NG feeds usually in the ward, but we're provided with extra fruit, extra snacks. We go around continuously and ask people what they would like. Our patients who are in for a very long time, we basically bring them in anything they want to eat, to just encourage them to eat whatever they want, really. So yeah, it's really important for us, and we've done a lot of training. Healthcare support workers, trained nurses and domestics even, on how the importance of nutrition in our burns.
Thanks a lot, Jackie. So it's important to remember, as Jackie says, that the wide role of all the members of the multidisciplinary team in emphasising nutritional support as a vital aspect for the burn patient. Pratibha, there's a question from the audience I just wanted to ask you about. One of the colleagues, William, has asked about nutritional requirement for a 3-month-old baby with a large burn, a 30% burn, and any particular advice that you would have about that, anything you would supplement breastfeeding with, and how. Do you have any comments about that? It's quite a challenging question to be asked.
Yeah, of course.
Any views?
Of course, Stuart. I mean, this is really a good question I would like to answer here.
because those who are actually dealing with the burns, they face sometimes these kind of patients and the real challenge. So in such situation, what we do at our center is we put a NG, and then we feed the breastfeeding, we extract the breast milk, and then you can easily feed with a very small volume to these toddlers or the infants.
Okay, thank you very much. Anything else that you would add to it that they need supplemented with, or is breast milk generally very good in that situation alone?
If it is not available there and not possible to preserve or maintain the hygiene of this breast milk, what you can do is there are certain formulas like Lactodex which you can use through this NG.
Thanks very much, Pratibha. Can I just ask Peter a couple more questions? These are questions from the audience, Peter. I might as well ask you them directly.
Yeah, certainly.
However, the question about jejunostomy, how early can that be performed? But I get that we went through a phase a number of years ago of having more invasive types of feeding, but I don't think we use that often now. Is that correct?
No, I'm not a big fan of stomas in burn patients for a variety of reasons. You can usually get jejunal tubes, which are equally obviously as good as jejunostomies. So I think from my point of view, and it's the same, we very rarely, if ever, use diverting colostomies for fecal diversion as well. Slightly different subject, but I think making stomas on the whole is not a great idea, particularly if the abdominal wall has been burnt.
That's very helpful. And second question for you, Peter, if you're doing jejunal feeding, duodenal feeding, do you give something to protect the stomach from ulceration, or do you just accept that the feeding probably helps with that?
No, I think you give both actually, and I think all our patients will be on a PPI.
That's very helpful. Thank you very much indeed. Thank you again, Pratibha, for a superb presentation, and thanks to the panelists for the comments about that. I'd now like to welcome my colleague, Nick Arkulis from the Burns Unit, Canada's Burn Unit, Glasgow Royal Infirmary. He and I worked together there, and he's been a superb colleague. And I just wanted to ask Nick if he would share his presentation with us on the surgical management of the infected burns wound. And this is part of a multidisciplinary series of presentations from the Burns Unit there. So I've indulged myself by getting some of my great colleagues. So welcome, Nick.
Thank you, Stuart. Can you see my presentation?
Yes, thank you.
Yeah, perfect. Okay, thank you for inviting me. As Stuart said, my name is Nick Arkulis. I'm a consultant plastic surgeon in Canada's Burn Unit in Glasgow, where we recently were successful in becoming the National Burn Centre for Scotland after a while, which was largely due to the efforts of Stuart, actually, who then retired and left us. But it's a great unit to be in. And Stuart's asked me to talk a little bit about the surgical management of the infected burn wound. I just have 2 slides for you. I'll keep my presentation really short because it's followed by some good talks by my colleague Leah Payton, who is the burns lead for intensive care, and then Dr. Basler, who's one of the anaesthetists in theatre, who deals with burns quite a lot throughout his career. That's the one reason why my talk is short. The other is just to make a case in point that the role of the surgeon within the MDT setting is not as big as perhaps we should we consider. So the first one is really just looking at strategies to manage an infected wound in the ICU, and the second slide is really about surgery for infected burns. I don't want to repeat too much because Prof. Javolski's talk was excellent in that matter. Previous colleagues and Stuart and some panel discussions have alluded to that. But for me, my personal feeling is that sometimes it's not easy to decide if a patient has an infected burn wound. And I often rely on colleagues, especially the microbiologist, but also colleagues, all other colleagues in the MDT to make that decision. And once it has been decided that or ICU patient has an infected burn wound, we manage it with an MDT setting as well. And obviously, one of the questions at some point becomes whether this patient needs further debridement for source control, and whether that debridement should happen in theatre. There are some bedside interventions that we have found helpful in ICU. Obviously, the prevention strategies that Prof. Chawalski also mentioned earlier, so I won't go into much detail there. Having our own dedicated ICU cubicles, which has been an issue during COVID, with patients being moved out to the general ICU area. But in an ideal world, we'd like them to be in their own cubicle with positive pressure and various prevention strategies going in. I'm not going to speak too much about antimicrobial dressings because everybody has their own preference. I'll just mention a couple of things that I found useful. The first one is the role of Flammacereum, and you can that's almost a prevention strategy in a way. So Flammacereum is contains silver sulfadiazine and cerium nitrate, and the cerium nitrate replaces the calcium molecules in the burn eschar. And so what it does is it hardens the eschar and it tans it. It almost makes it look like a pickle, for lack of a better word. And what that does is it makes it a bit harder for infection to get into the burn eschar, and it also temporizes the wound. And we use that sometimes when, for various reasons, we cannot take the patient to theatre very early to do an excision, either because the patient's too unwell, or in elderly and frail patients that we're not sure how they're going to behave physiologically. We like to temporize with Flammacereum, and that's a strategy that we found to be very successful. So I wanted to mention that here. And the other is actually something that I've only seen with you, Stuart, and when there are organisms that are aerophobic, so they can survive in exposure to air, sometimes nursing a wound exposed would be a useful thing. And I remember we had a patient with motor-resistant Pseudomonas that we couldn't get it to respond to other measures. So we did that, and the patient got much better with just using a simple strategy. Obviously, we had to make sure that the patient didn't get cold, but that was slightly easier to do in a warm cubicle. So those are the two things I wanted to mention about dressings. Very often it's easy to do debridement at bedside, especially if we've previously covered the wounds with allograft and the allograft has failed, or our autograft has failed, or there's slough. And this is potentially something that we could do bedside before the patient goes to theatre. And then I've added a photo there of one of our new shower cubicles that I have found to be exceptionally useful. Like Prof. Chawalski, I don't really know the evidence behind that, but anecdotally, I think, or I couldn't find the evidence behind that, but anecdotally, I think showering patients frequently improves their survival. So we try to do it once weekly. We use this shower cubicle, and as you can see, the insert there and the tube underneath can be replaced. So we only use one per patient for infection control measures. And we can move those in ICU, or we can move those in theatre, and we can shower the patients if required. So those are the strategies that I found are useful for infected burns in ICU. And then when it comes to surgery, I've already spoken earlier when Stuart asked me about the importance of having the right team and the right theatre setup. You asked me to talk a little bit about how to reduce bleeding, Stuart, during excision. And so these strategies can apply to burn surgery in general, but as we know, early excision is associated with less bleeding, or again, delayed excision with less bleeding. And there is that area in between where the patients bleed more. Again, the Flammacereum, we have found that once it establishes a nice firm eschar, you can then go with the diathermy and excise it, and it bleeds a lot less. Obviously, infiltration with adrenaline, so we tend to use 1 in a million concentration, or 1 in 200,000 if we are expecting to harvest skin grafts from the scalp. Adrenaline soaks, some units use phenylephrine soaks. We use tourniquet for limbs. When indicated, a fascial excision is a lot faster and bleeds a lot less than tangential excision. In big burns, we will have 2 monopolar diathermies and 4 surgeons in theatre to speed the process up. Obviously, we would optimize the patient beforehand, including their clotting. Tranexamic acid is something we often give a patients, and as you know, it has found its way now to polytrauma and ATLS guidelines, and we've extrapolated from that, and we're using it in burns. And there is, for those who use Lexobrid for certain areas, now you wouldn't use that on an infected burn, but enzymatic debridement has been shown to be associated with less blood loss than traditional surgery. We've covered the hypothermia. I've mentioned all these elements before and how we manage to keep the patient temperature steady. As we know, hypothermia is an independent mortality in burns patients, so it's incredibly important to keep the temperature regulated. And then it's a matter of, do we need to cover the wound, and what do we cover it with? If there is a small burn that's infected, would you autograft it straight away? Personally, my feelings is yes, if in the right setup, of course. If it's not grossly infected, I think excising a small burn gives you source control. With the right antibiotics in a stable patient, you can autograft, but again, that is for small wounds. For bigger wounds, my personal preference is allograft, cryopreserved allograft. I find it superior to other dermal substitutes. I would be very, very reluctant to use artificial dermis like or animal-derived dermis like Integra or BTM, especially in the presence of infection. But I'm aware that, but we can discuss this in non-infected patients in areas where it's important to preserve dermis. That's really all I had to say. That's kind of my role as a surgeon in the management of these areas. Thank you very much.
Thank you very much, Nick. You've given us a vast amount of information with great economy of time. I'm very grateful for that. So Dr. Ampoma has successfully been able to join. So Nick's speaker is Leah, consultant intensivist from Glasgow. Both if you wait, and Leah will go next because her presentation dovetails with Nick's, and then you present after Leah. So Leah, please may I ask you to share your presentation and to tell us about the intensive care side of the multidisciplinary management of infected burns.
Of course, Stuart. I'm just going to share my screen. If you could just confirm for me that you can see that.
Perfect, thank you.
Great, thank you. So as Stuart mentioned, I'm an intensivist at Glasgow Royal Infirmary, and as Nick has alluded to, we will take critically ill burns patients from across Scotland into what is a general ICU. And hopefully over the next couple of minutes, I'm going to talk a little bit about how we try and identify and manage infection in those patients. So as others have spoken about very eloquently, critically ill burns patients do pose specific challenges in terms of their propensity to infection. Their skin loss, immune dysfunction, and hypermetabolism render them susceptible to repeated bouts of sepsis and therefore antimicrobial resistance. However, working in general ICU, we recognize a lot of these features in some of the other patients that we see, like those with acute necrotizing pancreatitis or upper GI perforations. So I think it's important to recognize that there may well be relevance within the generalized sepsis literature about how we manage critically ill burns patients. So the first question that our team would generally look to answer on a daily basis is, does this critically ill burns patient with a significant ongoing inflammatory response have an infection? And really there are multiple things that play into that decision. The foremost of which probably is the clinical features of the patient on that given day. And that is aligned with specific laboratory parameters like CRP and potentially procalcitonin, and occasionally with imaging, and integrated by the whole of the burns MDT, so our surgeons, ourselves as intensivists, potentially anaesthetists, and also our nursing colleagues, to make a decision about whether there is infection present. And I would say that the key factor in influencing that decision is the trajectory of the patient. So we would be much more concerned by the development of a moderate pyrexia in a patient that also has escalating vasopressor or ventilatory support requirements than we would be by the moderate pyrexia in isolation per se. Once we've identified that there is infection ongoing, we're then looking for the source of that infection. And there are probably two key culprits in that regard for most of our critically ill burns patients, and those are the chest and the burn wounds. And I guess in my experience, it's probably unusual for pneumonia to drive an increase in vasopressor requirements that's not preceded by the ventilator support having to go up. So if there's sepsis afoot and the chest x-ray is reassuring and the ventilatory support is reassuring, that generally prompts us as a burns team to have a look at the wounds themselves. And then if we're reassured by the appearance of the wound, we'll go looking for other potentially less common sources of infection. Once we've identified that there is a source of infection, we then need to think about how we address that source. And for the vast majority of patients, that will include some form of antimicrobial therapy. But that's not a simple decision. It initially seems quite binary, but we need to give the right drug. So that targeting the perceived source of infection and organisms that have been previously identified on screening of that source. We then need to give that drug at the appropriate dose, bearing in mind that burns patients are hypermetabolic and that they have altered volumes of distribution. And we're starting to see some evidence now of antibiotic bolus versus infusion in the critical care literature. And it may be that over time our practice in this regard will change. And the third thing that we need to bear in mind is that we're giving that drug at the right time and for sufficiently long enough that we benefit the patient, but without necessarily exposing them to the risks of antimicrobial resistance, which, as others have alluded to, is important both at a patient level, but also at a unit and systems level. And then beyond that, we have to think about whether we're needing some form of surgical source control. And for those with burn wound infection, again, as others have alluded to, that will involve some form of debridement. Now, that's not risk-free, and often in that situation, what we may encounter is short-term physiological pain for the patient, at the potential benefit of long-term prognostic gain. So speaking of physiological sequelae, that's, I guess, where my role in proceedings come in as a critical care physician. So what do we do to support the patient's physiology in the context of burn wound infection and more generalized sepsis? Well, the first thing we do is try and optimize the filling of the cardiovascular system. Now, I always think for one of the first things that we learn to do as doctors, fluid prescribing is actually fundamentally very difficult. And particularly in burns patients, when a lot of the tools that we would use, like stroke volume variation or passive leg raising or point of care ultrasound, are either invalid or impossible. So we're quite often left with the situation of giving a fluid challenge and then assessing the response to that. And then we would repeat it if we perceived it to be beneficial, or cease and alter our approach if we perceived that there was no benefit from that. Often for septic patients, that fluid filling or fluid removal needs to be supplemented with some form of vasoactive support, usually to counteract the systemic vasodilatation that occurs in the context of sepsis. And sometimes they'll also need to be positive inotropy delivered pharmacologically to support the function of the heart if there's a sepsis-induced cardiomyopathy. Physiological homeostasis is also fundamentally dependent on the function of enzymes. And as we all learn earlier in our careers, these enzymes function best at a certain pH and temperature. So if you have a septic patient with an extreme pH or temperature disturbance, then we're looking to correct those with renal replacement therapy, generally in the setting of acid-base homeostasis. And as Nick has alluded to, we're increasingly using the endovascular cooling catheter to address hyperpyrexia. And generally speaking, that's temperatures in excess of 40 degrees, where enzyme dysfunction might actually be adversely impacting organ function. And then lastly, just to reinforce some of the messages that have been delivered by others, it's important that we're providing appropriate nutritional support, and that the type of nutritional support that you might provide with intercurrent infection might vary from that which you will provide out with that infection, particularly if there's an intra-abdominal issue afoot. And the last point I want to make, just in the interest of time, is around about the role of the team in analysing what we can do better as we move forward. And that applies not just at a patient level in terms of the various means by which we can improve our infection prevention and optimise nutritional support for that patient, but also at a systems level. And I think in that respect, the value of cross-specialty case review can't be underestimated. If it's done properly, if it's interrogative rather than confrontational, then it's an excellent vehicle, both for improving care, but also for improving team dynamics. And then lastly, I think there's emerging scope for addressing the capillary leak, the immune dysfunction and the hypermetabolism predisposing to infection within our burns patients. That, I hope you'll agree, makes this an exciting time to be involved in burns critical care. And I'll happily take questions towards the end, but I'll maybe hand you back towards Stuart at this point in proceedings.
Thank you very much, Leah, for a wonderfully clear presentation. Are you okay to undo the share of your presentation? Thank you very much. Leah, can I ask you specifically, first of all, about, for people who are working in limited resource settings, who have a patient with septic shock, is it how realistic is it for people in limited resource settings who don't have access to complex intensive care monitoring to use vasoactive support? Because many of our audience will be from settings where there isn't much in the way of complex invasive monitoring possible. But they will be treating some patients with septic shock who might conceivably benefit. I know it's a difficult question for you because obviously you work in a place where you have these things, but what's your view on that? Because there will be situations where they have a patient who's desperate with septic shock and they want to try and do more for the patient. Any thoughts about that?
Yeah, so I guess we are fortunate in that we do have access to invasive monitoring and cardiac output assessment, but there's nothing better than putting a hand on a patient to try and gauge the adequacy of peripheral perfusion. So I don't think the value of that should be underestimated. And I remember as a trainee myself being told that, you know, the seniority of assessment that was required by a patient was dependent on the level of perfusion to which the the arms and legs were perfused. So the junior colleagues would see the patients that had well perfused peripheries, and the senior colleagues were seeing patients that were less well perfused peripherally. So I don't think we can underestimate the value of putting a hand on a patient, gauging cerebral perfusion through talking to the patient potentially if they're unintubated, and using urine output. So all of these things are God's cardiac output monitors.
Thanks very much, Leah. If I could please now ask a similar question of Shobha Chimania, Dr. Chimania from the Burn Centre in Indore. Are you still with us, I think, Shobha?
Yes.
Shobha, can I ask your perspective, working in a centre with many patients and very finite resources? Leah's shown us with wonderful clarity the principles of modern critical care. And how can you, in your setting, we have a large audience from around the world, many of whom are working in limited resource settings. Any words for them about how they can apply these principles of optimum critical care for septic patients in limited resources? What are your views on that? Thank you.
Thank you very much for this question. Yeah, very interesting question. We don't have a burn ICU like most limited resource centers. And then the surgeon has to become a very good friend of the anesthetist, and the team of these two would manage the patient if the patient goes in shock. As Leah said, that you must have a multidisciplinary team to help you. And I would very much agree with her, because we contact the cardiologist very often, and the cardiologist comes and helps us to know that which drugs are going to be more useful, because he's more intensive care oriented, and clinically he can tell us so much to help. Many such patients have been helped with these three inputs. And we've managed ventilators, and we have managed support, vasoactive substances support in the ward, but with lot more attention by the team personally. And with very little monitoring system, we do have a cardiac monitor that is used, and that gives us the heart rate, blood pressure we have to take manually. We get the ECG sometimes, and we get urine output. So these are the monitors that we get. But acid-base balance, yes, we do find out, and we take the help of these specialists to manage. We're not able to salvage very sick patients, but small infected burns we have operated, and we have been successful in salvaging.
Thank you very much, Shobha. That's great. Thank you. Can I just ask Peter Jaworski finally, any further comments about the critical care side that you would like to make, Peter, in terms of what Leah said? And then
no, I think no, I would agree with all she said. And I think what we have learned over the last 25 years at St Andrews is actually integrating the anaesthetist and intensive care specialists into the burn team has really produced quite marked improvements in care for our patients, not only around critical care, but pain management, itch management, planning, procedures, whether they be on the ward or in the operating room. So actually having, the intensivist as a burn physician, as it were, is really important. Often, as with a lot of teams, and you see this in sport, and particularly in international sport, a team is not a bunch of people who get together at the last minute to do something. A team is a bunch of people who work together, train together, share common goals and values to actually undertake the task they're supposed to do. And often in healthcare, teams are thought of as just people who are thrown together at the last minute to do a procedure or whatever. That's not a team.
Thanks, Peter. Thank you very much. That's just hugely important principle that Professor Jaworski's just given us there. And you can tell from the way I'm speaking about my colleagues from ICU and anesthesia in our service, how vital I feel that as well. It's now a real privilege. We've resolved the issues which delayed Mr. Apoko Ampoma, FRCS plastic surgery, from joining us. He's now able to share his presentation with us. It's been my huge fortune to work with him for almost the last 20 years. He is a consultant burns and plastic surgeon who, along with his colleagues, Mr. Lang and Mr. Paintsall, has developed an absolutely superb plastic surgery service at Korle-Bu Hospital in Accra, Ghana. And his level of expertise in infrastructure and service development is such that he's now recently been appointed the Chief Executive Officer of that hospital, which is one of the largest hospitals in Africa. So welcome Apoko, who's going to give us some of his insights into the management of burn infection. And just to let the audience know that there is one more talk after that, a recorded talk from a consultant anaesthetist. Just because of the way things have worked today, we are going to run over by about 20 minutes, but it's wonderful that so many people have stayed with us. So I hope you'll stay with us too for the last talk. So welcome to Dr. Apoko Ampoma.
Thank you very much, Stuart, for this opportunity to join such a distinguished panel. And I just want to share just a few tips or a few perspectives from the sub-Saharan African setting regarding management of burn patients and burn infections. And I think a lot has been said already, well ably by Shoba and Professor Jaworski. So I think I'll just be very brief with my comments and just talk about the fact that in the our part of the world, large burns tend to be quite common, and so infection is something that one has to expect because of sometimes the circumstances surrounding the burns. Mass burn casualties often occur in our setting, usually due to fuel and gas explosions, and the pre-hospital handling of these cases makes them predisposed to wound contamination and wound colonization. And so that is something that is to be expected. And of course, we also have various abnormal or traditional practices which result in the various agents being applied onto the surface of the burn wound, and which result in burn wound infection. And patients generally also present late to the hospital, so by which time either the wounds are heavily colonized or sepsis are setting. And it's important that when it comes to picking up the symptoms or the signs of burn wound infection in our patients, I think a lot has been said about that already, so I'm not going to belabor that point. But then it is quite common for people to believe that because we live in a very warm climate, hypothermia is uncommon, but it is something that we do find quite often, especially in children and the elderly, that they can become hypothermic. So that should be factored in. And in regards to predisposition to burn wound infection, a lot of it is also because the cost of the burden of burn care is on the individual patient and their families. No matter the size of burn, even with our insurance policy that has kicked in, the maximum amount that they will pay for a burn of any size is a money that is now the equivalent of about £100. So you can imagine managing a 40 to 50% burn on just £100 budget. So a lot of the time, the patients have to bear the burden of buying the dressing, etc. So, and of course, with regards to the dressing, there are limited options. We've tried to mitigate this by setting up our own factory that produces sterile dressings, so we're able to provide for those patients who are needy. And so for us, the mainstay of preventing infection is to anticipate it and also to work within the team to ensure that the basic things like regular dressings, hand hygiene, and also various precautions are taken. And it's important to for us also to make sure that catheter care, care of central lines where they are set, tubes, etc., is very, very, very important in preventing. But if you go across many hospitals in the sub-Saharan region, there's no clear antibiotic policy. So this results in sometimes the generation of multi-drug resistant bacteria, and that can be a challenge. But it's important that the local microbiologists there's liaison between the burn specialists and the local microbiologists. Unfortunately, many centers do not have a microbiologist, so it's they use their best guess to to deploy antibiotics, and it's important for us to also be able to differentiate between wound colonization and then active wound infection, which I think Professor Jaworski so brilliantly espoused. And so one of the ways we can also prevent benefit is to also be able to treat some of the smaller burns quite quickly with early excision and grafting. But of course, it has to be properly planned, and the precautions must be taken to prevent undue blood loss. The multidisciplinary team approach to care is very, very crucial in terms of nutrition, in terms of physiotherapy, in terms of the other aspects of the care, which would result in at least patients getting the best outcome and being able to get healed as quickly as possible. And many times, donor site infections are also one of challenging problems that often happen, and with the appropriate methods or prevent strategies, I think that can be reduced to a minimum. But in summary, I would say that enforcement of IPC policies is very, very crucial in preventing burns. Unfortunately, many of the wards tend to be generally overcrowded, and so that also affects the spread of infection among staff and among patients. And then the issue of teams, working in teams. There's at the moment quite a high attrition rate among nurses who work in burns because the work is quite difficult and for the same benefit. So it is quite difficult to keep expertise, especially nurses, in burn care for long. And so those are some of the challenges on the ground. Antibiotic stewardship continues to be a challenge, and prioritization of wound closure in terms of early excision and grafting is also a challenge for some of the centers, but the bigger centers are able to do some to a large extent. And of course, nutrition is very, very key, and having a nutritionist in your team helps to prevent a lot of, or helps to optimize the patient so that reduces the incidence of sepsis in these patients. So I think those are some of the comments I'd like to make from the African perspective, and I'm happy to take any more questions. Thank you.
Thank you very much indeed, Opoku. I know that you have been a fierce advocate for nurses within your service. Can you tell me about some of the things that you've done about that in terms of trying to optimize retention of nurses in the service and professionalism?
Thank you very much. I think with that, I have you to thank largely because it used to be that, in fact, in Ghana, we didn't have any specific training for nurses in terms of burns and burn care. And with the support of yourself, Research Africa and Interburns, we've been able to hold a series of training programs, especially the postgraduate course in burns and plastic surgery nursing. We've had 2 cohorts of nurses, over 80 nurses have graduated from this program so far. And I think that is one of the key things that has helped us to retain the nurses and retain their interest. And so if I just this morning, and they formed groups that even go around educating patients on burn prevention, and having that value added to them has been quite motivating for them, and it's they continue to engage, and so that is one of the things that has helped us to retain a cohort of nurses who have very keen interest in burn prevention and burn treatments. And I'd like to commend that to other countries, especially in the sub-Saharan region, to be able to undertake some of these educational programs for the nurses, because they are really the backbone of the burn service.
And thanks to Poku. Peter said it in his concluding remark of his last question, and you said it there. And I remember when I asked you about 6 or 7 years ago, is there anything we can do to help with your service? What does your service really need? And the thing that you said is, we need support for the nurses. That was, and it is vital that people have regard for this aspect, as Peter said, and as Shobha has shown in her service of building the whole team as a key component of managing the burn patient. Any of the panel have any comments they'd like to make further? I just want to ask Jackie Iverson as the nursing manager. Professor Jaworski mentioned in the course of his last comments about the vital aspect of pain management. And Jackie, this isn't directly related to infection, but it's very, very important in infection management, because a lot of burn patients get into a vicious cycle because of pain. Can you just share with the audience how our nurses in particular in the unit manage pain, and what's available for the patients in terms of the pain service?
Of course. We're very fortunate. We've got a pain team. The specialist nurses visit the ward daily and review all the analgesics. We have a consultant who visits weekly, and the whole team are present at the weekly MDT, which is really useful. And we're able to call them anytime. We've got a fabulous relationship with them. We can get the nurse practitioners to be present during the wound dressings, which is really helpful for the patients, obviously. And out of hours, if we're doing dressing changes on the weekends, we do have access to the anaesthetist as well, which again is very helpful for the patients.
Thank you very much indeed. Thanks, Jackie. So we now have one final presentation. It's a recorded presentation from a superb colleague of mine, Dr. Mike Basler, consultant anaesthetist who has a special interest in burns. If the audience would please excuse me, I just wanted to give leave to some of the very senior colleagues, such as Peter, Shobha, and Opoku. If they need to leave, you're welcome to leave, because I know you're extremely busy and that we're going to run over a bit. I just want to thank them hugely for their contribution and for sharing their expertise and experience in such an accessible way for our audience. If the audience would just bear with me, I'm just going to set about sharing the last presentation, Dr. Basler's presentation, which is really worth hearing. He's a very inspirational speaker, and he's going to talk about anesthesia in the infected burn patient, and also give us his views on the world and on care of patients generally.
Hello, my name is Dr. Mike Basler. I'm very grateful for being asked to speak today at this webinar. I've got 7 minutes to talk about anaesthesia, the transfer of sick burns patients to theatre, and management of fluid and some of the anaesthetic pitfalls. So I'll just fire ahead if you give me a second to share my screen. So, in a nutshell, what are we doing with a burns patient when they come into hospital to theatre? Well, we know that early debridement and grafting save lives. Debridement is a physiological insult, often on an unstable patient, particularly in what I would describe as being round 1 and round 2 of the management of a burns patient. I'll explain that later. Infections and multi-organ failure increase instability and then delay debridement, which again leads to a worse mortality. So we want to try and avoid infections. We want to treat multi-organ failure, or at least support it as best we can. And the teams that do this are the ITU and the burn care staff with management and inotropes, management of renal failure and dressings and treatment of infections. But this is often difficult. Now, the key issue is that any form of transfer, even to a CT scanner and anaesthesia, could facilitate the patient get better, including debridement. But by their very nature, these patients are very unstable, and these transfers can make them worse, which in turn can lead to the multi-organ failure or the infections getting worse, and then they require more debridement, and we're back at the very start again. And I think I'm going to talk about processes in a minute, but I think there's 2 real key lessons to learn in the management of these patients. The first is that if you practice a few simple disciplines with every burns patient, then you can be successful. The converse of that is if you constantly make the same errors and repeat them, you'll have a burns unit that doesn't make any progress. There's an American football team who have a kind of tagline that says they have a commitment to excellence. And I would suggest that every patient needs that, but a burns patient needs it particularly because, as I'll talk about, they are very likely to fall down a hill if you're sloppy in the management of their care. So, as an anaesthetist, you can't see this. I'll see if I can move this. But this is the saturation curve that everyone knows, the intensivist knows. Now, a burns patient is someone who kind of will be up here, but very quickly has the ability to fall down there. And what I say is that a sick burns patient is a sneaky patient. Often we have great difficulty diagnosing infection, and there can be a variety of things going on, but the inflammatory process that's going on in the burns patient, by the very nature of the burn, often masks this, and we need a really high kind of clinical suspicion if things are going wrong. There's a man called David Brailsford who basically was thought to revolutionise the British Olympic cycling team. And he did it by a thing called marginal gains. And what he did was he took every single little bit of the cycle team, be it the management of cleaning their hands in the changing rooms, to the size of the saddle, the helmet, the tyre. And by chopping a tiny little bit off each of those things, he made the cycle team very, very efficient and they won lots of medals. And we can't get a drug or a treatment that can switch off the inflammatory process in a burns patient. So what we need to do is we need to look at all these tiny little marginal gains to allow us to work through this massive pathophysiological insult and then lead to a good outcome. The other thing that many developing countries will tell you is that they rely completely on Toyotas. They're fabulous cars. They're almost indestructible. And Toyota have a philosophy called the lean philosophy that has 3 components to it. The first component is a thing called muda, which means they don't do things that they consider to be futile. Now, if you're in the middle of a sick burn and someone comes up to you and says that they want to do a 270-page checklist, you tell them to get lost. What you should be doing is you should be getting rid of every single inefficient and futile process that stops you getting this burn patient to theatre and out of theatre as quick as you can, as safely as you can, to get them back into the safety of the ITU. They also talk about uneven processes. So if every Wednesday the surgeon who treats the burns patients decides to go and play tennis and he lets his junior doctor do the debridement, then the guy that does the Monday and the Friday will have no chance of looking after this patient. So we should be applying the same commitment to excellence and standard to each and every individual patient. They also talk about a thing called Muri, which is that you do not give a team too heavy a burden. And that's very important when it comes to burns theatre. If you suddenly decide to be heroic with very limited staff. They will not be able to get all the things you need quickly. They will not be able to dress the patient, turn the patient, look after the sick patient, and you'll be in trouble. So I mentioned the 3 rounds of burn surgery, okay? And this is an easy way to think about how your burns patients present. So the first round is when they present acutely. And it's almost as if we need to get in and out of that round as quick as possible. We need to debride as much as safe as possible, but the reality is we're getting them in, we're getting them done, we're getting some allograft or whatever it is we're doing onto them, they're getting dressed, and we're getting them back to our high dependency or intensive care unit to get them stabilised. We're relying on Parkland formula, ventilation, we're trying to get them better. And that kind of will be unstable, but it kind of takes care of itself because it's very quick and in and out. We're really kind of pushing to get them back to ITU. The middle round, like an Olympic thing, is the sneaky round. And that might be the patient that's there for a week or 2 or 3 weeks. And they might be slightly unwell. They might have had a bit of multi-organ failure. They've got a chest infection. We don't know if they've got Pseudomonas. That's when you're really going to struggle to find out if they're revealing themselves as being sicker than you think. They might have their feet going off, you don't know. And if you just take them down and don't really look at them closely, you can fall down that hill. The final round is the bit when we're almost there, and it's really about the attention to detail to make sure that their electrolytes are good, the magnesium, all their healing things are good, they're well nourished, because effectively what we're doing is we're managing them well. And we're trying to get towards the end of a good cosmetic outcome. So I've put that up there, and it's really important. Just before we even do anything, the surgeon, the anaesthetist, and all the members of the team have to talk to each other. The surgeon talks to the anaesthetist and we agree what we want to do. The surgeon might say to me, look, the face is really important. I want to get the back done today. If we don't do the hands today, it's going to be a really poor surgical outcome. And I've got to be prepared to understand those surgical needs as an anaesthetist. I need to then go up to the intensivist and they might say, no, look, they've really been stable. But the nurse might say to me, yeah, his inotropes have been a bit up and down all day, or the patient's blood pressure, the urine output. So that's going to let me know how they're doing because I haven't seen them. And then we both need to kind of communicate with our theatre team to make sure that they are prepared. We're wanting to go in quickly and go out quickly. We've agreed the goals of surgery. What we also need to agree is the limits of surgery. So I need to discuss with the surgeon prior to transfer, how much blood loss are we going to accept? How much debridement are we going to do? If we can get away with more, shall we try and do more? Is it really necessary? How low are we going to let the temperature go? And if I start to get into trouble with inotropes and managing the patient's oxygenation, I need to be able to say to the surgeon, we're going to stop at this moment. The sicker the patient, the more experienced the team you need in theatre. That goes without saying. Don't be heroic. He who fights and runs away can live to fight another day. And preparation is key. And when you're in theatre, talk to each other. If you're a surgeon who works in a theatre suite where you are king and the people around you are so frightened to talk to you or to say, look, I think you need to stop now, then your patients are going to have adverse outcomes, however brilliant a surgical technique you have. Now, I never really got round to doing any of this, but people will recognise the revised box score. And as you can see, if you have an inhalational injury, that makes things worse. So that's part of my looking at a patient and saying, okay, this might be a more difficult patient to transfer. But I've kind of put up in the right-hand corner there the things that I think are incredibly important as well. Oops. So if the patient has significant pre-existing comorbidity and they're still alive, they might not have the physiological reserve to deal with all the insults. And that might not be apparent at the time that we resuscitate them. So I will look at that before I transfer or deal with the patient. Now, they all get renal failure of sorts. Some get worse than others. Some of it obviously is due to muscle damage. But if we've got increasing multi-organ failure slowly happening, again, I would suggest that your box score is going in the wrong direction. If we've got unexplained or unusual pathology that we wouldn't expect in our burn patient, then again, your box score, your risk of mortality or morbidity is going down. And never take a patient to theatre in the hope that that's going to cure some unknown pathology or deterioration. The very act of taking that patient to theatre will make them worse. You need to clearly know why you're taking a patient to theatre. If you think they're sick because of infection, take them to theatre to get rid of an infection. But if they're just sick and you don't know why, taking them to theatre is not going to make them any better. Laparotomy in a burns patient just frightens me. I've seen so many burns patients have acute abdomens and die. Controlled hyperpyrexia. I know that the staff are really struggling to monitor the temperature. That's a bad sign to me. So all of these things, I think, will push your mortality up and your box score down. So when I go to see them, I'm thinking to myself, first of all, where should this procedure occur and will they survive it? I'm thinking about, okay, how are we going to do a handover for transfer? Have I got things around me for the transfer itself, blood and blood products? Now, I'm only going to just put this diagram up, but infection causes instability. If we look at this patient, we take this patient to theatre, they're going to bleed a lot, they're going to have a septic storm, the inotropes and the fluid balance are going to be difficult to manage, and I'm going to probably need some blood as well. And they're going to come back and have a rocky few days, whatever we do in our HDU or intensive care unit. And so you need to think about that before you go and do what you do. Now, the transfer is like walking on this rickety bridge. It goes without saying that you need to tell the theatre when the patient is going to leave, because the theatre has to be ready. We want to be in quick and out. And I'm sorry, but if suddenly the consultant plastic surgeon has decided to do the mayor's daughter's nose job and the burns patient is sitting in recovery or out in the reception area for 4 hours, then that's just not good enough. These patients are sick, they need to come to theatre and they need priority. They need to be pre-warned. Take their temperature before you go down. So they'll come into theatre and you'll say the temperature's 38. Well, that's great. But actually the temperature might be 40 up in the ITU. And so they're now hypothermic. Have the blood products there in theatre if you've got access to blood products. Check all your lines. Halfway down the corridor, you do not want your inotrope line to have suddenly stopped working. Have some spare drugs, be it inotropes and emergency drugs. Have lines that are long enough and monitors that work and batteries that are charged. This is not rocket science, but every single little bit of the marginal gains that are lost mean that this patient is at risk. When you transfer the monitors first and the patient second, and you put the warmer on quickly. And if the patient's unstable, you can turn back. You can turn back and say, we'll come down tomorrow. Now, these are all the perioperative challenges that can occur. There's loads of them for anaesthetists and surgeons and intensivists when we're dealing with this. Okay, and commonly, I don't have an ECG. My saturation probe might be difficult. The ECG dots are on and off. My arterial line might get kinked as we move the patient. It's difficult to access to the urine volumes, etc. And the challenge which this picture shows is that the theatre is often crowded and I need to stand up and make myself obvious in the crowd at points. So that's why I've put it's a standing up anaesthetic. You need more than one person for the transfer and the anaesthetic, one maybe to do the chart, the other one to kind of watch the patient closely, particularly if they're sick. And if you have an anaesthetist who's sitting there drinking a cup of coffee, doing their chart and a bad burn, then you know to rehire a different anaesthetist. Now again, I'm not going to go on about temperature control, but I'm just going to tell you, take the temperature before you go down and put a warmer on prior to transfer. They will become hypothermic if the transfer is long. I've been asked to talk a little bit about circulation. So when I'm dealing with a burns patient, this is what my circulation is like. There's hundreds of holes with leaky capillaries. And so I'm going to be trying to do my best to try and plug those holes, but to essentially make sure that whatever I give stays within the main circulatory cabinet, the circulatory volume. In the first rounds, we're going to do the Parkland formula, and that's fine. Some people think it's they should get a gold medal just for remembering the Parkland formula. I've also seen people that are sitting there on day 200 and they're still trying to apply the Parkland formula. Remember, think of those 3 rounds. The first round, you can be generous with the crystalloid. In the second round, you're going to just be a wee bit wiser. And certainly in the third round, you shouldn't be overloading them. And what do we know? We know that there's ebb and flow within all the circulatory parameters, the cardiac output changes, the SVR, the vascular resistance can change. But also what we know is as soon as they get another insult, like an episode of multi-organ failure, a renal failure, infection, these things will change again. So we've got an unstable process half the time. And remember, inotropes kind of behave differently here in my experience. You need to, your noradrenaline, your adrenaline, whatever you're using, it's maybe not as reliable as you think. Again, I'm not going to talk about all the other regimes and the different things we're going to do, but I'm just going to say, as we talked about, the risk is of fluid creep. And you've really got this challenge, which is on one side of this diagram, we've got someone who's obviously in renal failure from myoglobinuria, and we need to make sure that our fluid volumes are good enough. But on the second side, we've got this awful picture of fluid creep and an abdominal compartment syndrome. Now, the balance to think about it is in terms of where they are in their journey. You're much more likely to get into problem 1 in round 1, which is if I don't give them enough Parkland or if I don't deal with things. But once we get to round 2 and round 3, if we're still piling in fluids, that's where we can end up. Simple, stupid. Remember I said don't be heroic? Look at this chap in the motorcycle. He's got 6 family members on a motorcycle and 2 dogs. That might sound great, but he might crash and have an absolute terrible outcome. So just do simple things. Look at all the blood loss that will occur. So what we're talking about here is we're going to infiltrate with lots of adrenaline. We're going to try and keep the patient warm. We're going to do good diathermy if we've got diathermy. And we're going to have reasonable goals without creating a bloodbath. It's very easy to convert a small burn or a large burn into a massive period of blood loss and instability. And this is what happens if we view debridement as some form of trauma. This is how we fall down the hill. We get acidosis, hypothermia, we get coagulopathic. It may be we don't die in the table, but what will happen is we'll have bleeding underneath our graphs, we'll have an unstable patient cardiovascularly, and all of a sudden, 2 or 3 days down the line in ITU, they're really struggling to keep this patient alive just because the surgeon decided that they wanted to do too much. So what do I do about fluids? Okay, so where are we with this? Are we early on in the journey? What round are we in? Round 1, 2, or 3? Where is the patient at that very day? Ask the nurse, do you think the patient's dry? How's their urine volume been? Do you think the patient's a bit overloaded? And then what we want to do is we want to look at the feet. How much feed have they taken in? Because that will be fluid, but also, are they absorbing their feed? If they've stopped absorbing their feed, what's going on? That's a wee warning sign. Now, we know that renal failure due to myoglobinuria is bad, but renal failure due to multi-organ failure is very bad. And that means I am kind of not only dealing with a tight compartment, that a patient that might hemodialysis, but also dealing with all the other inflammatory stuff that's going on that's caused the multi-organ failure that makes them unstable. I tend to give blood early if they're sick, and if we're talking about 6 patients, it's usually the most of them. I want the blood to be in theatre. I'm trying to be gentle with it, but I'm also not being stingy, and I'm trying to avoid crystalloid round 2 and round 3. I'm lucky because I have access to fresh frozen plasma, which I'll use. Again, this is personal experience, but if you don't have it, then just be careful with the crystalloid. I've put there, no man can be wise on an empty stomach. That's a quote. No burn will survive on an empty stomach. We know that. We know about all the metabolic feeling. And what I would tell you is if you're using inotropes, they don't work on an empty circulation. So you've got all these things going on. You've got a busy theatre. You've got patients that are unstable with leaky capillaries that don't respond to inotropes. And you really need to have good judgment. And you don't need to be thinking about things that are futile. The last thing I would say, which came from us from our great friends in Ghana, is that entropy is normal. chaos occurs all the time. So you really want to be watching like a hawk with all of these things going on. You're communicating with your team, your surgeon's communicating with you, and hopefully you get a good outcome. Thank you very much. Just end.
So Mike is on leave and he can't be with us today, but you can see he's an absolutely wonderful speaker, and I'm hugely grateful to him for the insights that he's given us there. So we're going to finish shortly, and I just want to ask one or two things that, going back to things we discussed before. Specifically, I want to ask Nick, a couple of the speakers have alluded to the use of allograft and or other skin substitutes. And I'd just like to ask Nick Arkulis, consultant surgeon from Glasgow, about the value of allograft in the infected burn patient, in the difficult burn patient.
Thanks, Stuart. I think if you can access it, if you can get allograft of good quality, in my opinion, it's indispensable. I'm a very heavy allograft user. In the context of an infected burn, I don't think it has an equal. It does a few things. It temporizes the wound beautifully. It is almost like for like, because initially it takes like a normal graft until it gets rejected. So it provides you with that barrier, and it also prepares the wound bed. So when you go back to it to apply your autograft, you just find that the autograft take is far superior. There are some downsides. It's expensive. Procuring it is difficult. There is always a theoretical risk of bloodborne virus transmission. It might also either preclude you or make it very difficult to have a solid organ transplant in the future, and those are all kind of slight difficulties. But I'm a very keen user of allograft, especially in a difficult patient, unstable, that requires debridement and some sort of wound cover.
Thank you very much. Can I just bring in Shobha and Dr. Shobha Chimania now, and to ask a similar question. I know, Shobha, that various centres in India have made huge efforts to obtain allograft in the last 15 years or so, with some success, but it is very challenging in many of the cultures around the world. And what's your perspective on different alternatives to allograft or use of allograft in your setting for management of difficult wounds? What's your perspective on that, please, Shobha?
Well, we established a skin bank in 2011, and we have a good skin stock. Donor skin is there, generally available, and we have used it profusely on infected burn excision, and we've had very good results with that. We even use allograft on early excision and grafting when there is paucity of autograft. We use that. So we're very happy to use that, and we don't have any other options like porcine skin or the other synthetic substitutes. We can't use them. Very expensive.
So do you feel, for colleagues around the world, it's something which is really worth making the effort to develop if they haven't yet got that resource in their services?
I would strongly recommend for this, because it's a very useful resource for moving forward with improving outcomes and salvaging serious burns, especially infected burns and large burns. I think it's a very important resource, and it's possible in low resource settings to have it.
Can I just thank you very much, Shobha, and thanks for everything. Can I just finally ask Peter for any other perspectives on that subject, Peter, about the surgical aspects?
I think the skin replacement obviously is key. I would agree that allograft is currently standard of care for dealing with bigger burns and infected burns. I think, however, as our anaesthetic colleague rightly mentioned, we should be thinking about how we do things better. And actually, allograft does have long-term immune consequences. Dr. Patton very rightly said we should be looking at how we do things better. So I think it's all of us need to be searching for other viable skin alternatives which don't have long-term consequences. And I think for infected wounds, yes, I don't think anybody would sensibly put a skin substitute on, but I think the newer ones, the polyurethane, the BTM, I think is much more resistant to infection than say the collagen-based ones, Integra and that. So I think that's where we need to start looking and looking at different ways of doing things.
Thank you very much, Peter. Thank you. And on that note, I'd like to draw this webinar to a close. First of all, I want to give my thanks to the audience who've attended. We still have a large number of attendees with us. Hugely grateful to all of you from around the world. I hope that you've appreciated these fantastic insights. I've learned a lot this afternoon, and I hope that you have. And I'd be very grateful if you can let your colleagues know that they can view recordings of this through the BFIRST website after a number of days, and that recording will be there for a long time. I'd like to extend my huge thanks to Dr. Shobha Chimania, Professor Peter Jaworski, Ms. Pratibha Sharma, Dr. Puka Ampoma, and my colleagues, Nick Arkulis, Leah Payton, Jackie Iverson, and Mike Basler. So thank you all for your absolutely superb contributions. That was really great, and I'm so grateful to you all. Thank you.